2019, shortly after we became an official nonprofit coalition. And so this is kind of some big milestones for us. As many of you know, the Rare Access Action Project, we are a coalition of patients, providers, healthcare professionals, as well as the life sciences. And we look specifically for solutions to patient access issues. And so you'll notice that as we approach many of these issues, that we come at it from what's best for the patient. And so we would like to welcome you to this event, and we have a wonderful panel this morning to talk about the intersection between innovation and the patient journey. Many of you will remember last year in Boston, we had a very emotional panel as Bob Coughlin spoke about his journey through cystic fibrosis and his son. And so we have a terrific panel this morning. And I will turn the time over to Terri from Merck, who heads their state government affairs, and she will introduce this panel. Okay.
Good morning, everyone. How's everyone doing? First, you all are congratulated to be here this morning. I don't know if you came in on Sunday or yesterday or just made it this morning, but that was an accomplishment in itself, and that your eyes are open. If you were on a flight, I know my colleague Olivier didn't make it in until 2 a.m. this morning. So, and unfortunately, we're missing one of our panelists because he's not here yet, but we're hopeful that he'll still make it today. So Mike, thank you. Mike and I go way back, and we were just talking about how much our industry has changed. I lead the State Government Affairs and Policy team with Merck, and we are a major pharmaceutical manufacturer that's global. But we have seen, and Mike and I have seen, as many of you have seen, how the industry has changed. There are a lot of companies that aren't around any longer for a number of reasons. But that's part of the challenge we face with rare disease. Investing in this business is hard, it's difficult, and it's risky. And so those that are still in the game, it is so important that we all work together to make sure that we can continue that journey. So on that note, my rest of my job is to make sure I facilitate the great discussion that you're going to hear from these individuals. So first, let me introduce Jessica Blackford-Cleeton, who is the National President, Advocacy Leader, Public Speaker, Research Collaborator, and long-term, you're going to have to say it.
Peritoneal.
Thank you. Peritoneal Mesothelioma survivor. And Jessica will speak more about herself, so Jessica, please feel free to come on up. I'll also introduce, here, I'll move this over here. Bear with me, got it all here. Also introduce Emily McGinnis, who's the Chief Patient and External Affairs Officer at Taysha Gene Therapies. Come on over. And then also John Conrad, who is CEO of the Illinois Biotechnology Innovation Organization, iBio. All right, so let's get started. We'll just pass the mics along. So as you heard, each of these individuals really represent diverse stakeholders in the ecosystem that we all work in. So I'm going to ask you all, based on your, your organization and the audiences that you represent, to introduce yourselves, and then also give the audience a perspective of how you're engaged in the rare disease space. Whoever wants to start.
Okay.
Okay. Can you hear me okay? Okay. Hi, I'm Emily McGinnis, and you mentioned I'm with Taysha Gene Therapies. I always like to say I think I have the best job title. I'm the Chief Patient and External Affairs Officer. So really my job is to ensure that the patients are at the center of everything we do at Taysha, from understanding their needs before even going into clinical trials, and just along the journey as well. Working really closely with patient advocacy groups, and really just seeing everything we can to move things forward. We're working particularly on a gene therapy, a one-time gene therapy for the treatment of Rett syndrome, which is now in its pivotal trial. So we don't have anything on the market, but we're working towards that. Again, rare disease. Prior to coming to Taysha, I've been at Taysha for about 6 years, and talk about the ups and downs of the industry. We've seen that, but I was at Avexis Gene Therapies, which is now Novartis, where I had the opportunity to work on Zolgensma in a similar role, as well as on newborn screening and early diagnosis efforts. So I just want to congratulate all the work that's actually been done in newborn screening, because now every state in the United States is screening at birth for newborn screening. More on that later, but definitely very impactful for the rare disease community and those living with spinal muscular atrophy.
Good morning. My name is Jessica Blackford-Cleeton, and I am a patient. First and foremost, I have a rare disease cancer called Mesothelioma, peritoneal, so it's in my abdomen. I also have had many melanomas. I have a rare gene abnormality, and I also have a rare bleeding disorder. So I'm rare across the board. I'm very lucky. But as far as mesothelioma goes, I think less than 10% make it 5 years, and I'm on year 11. So I am the unluckiest person you will ever meet. I really dedicated my life to advocacy, helping other patients along the way, and trying to figure out what's next so we can have a better option for patients like me. I do work with the CDMRP, which is the Congressionally Directed Medical Research Program. I peer review for them. Mesothelioma is under that, and we've had so many cuts in the last 2 years, almost $1 billion. So we are fighting so hard to get some of that back, and I'm on the board for the Mesothelioma Applied Research Foundation, which is the only nonprofit foundation for mesothelioma out there. So I work, extremely hard and put as much effort that my body can do to get the word out there that we are here and we exist, and we need better options.
I will share it. My name is John Conrad. I'm president and CEO of iBio. So iBio is the state trade association for the life sciences in Illinois. So we primarily focus on the pharmaceutical and medical device industries within the state. In Illinois, that's about a little over 250,000 jobs that are supported by the industry. And a lot of what we do is on the advocacy side. So we work a lot in Springfield and DC, really focused on how do we help the industry grow within the state. We do a lot of work on access issues, which is, we can talk about here in a little bit some of the access issues that we've been working on in the state. And we also do a lot of education. And through that, Illinois and Chicago has really grown to be a very strong hub in rare disease. We have a lot of companies, with Avexis. We also had Horizon. All these companies that have sprung up within Chicago are spinning off new companies off of them. Right? And so we continue to see new companies growing in this area, and it's an important area for our community. So,
Great, thank you all. And I'm going to give you the microphone, and I'll just speak loudly. Can everyone hear me if I speak up? Okay, great. I need the mics. So thank you all for those introductions. There's a lot that you are doing and carrying. So I'd love to hear what you've learned from your experiences as a patient, working with patients and patient groups. And maybe we can start to talk about some of the barriers that patients experience through diagnosis and treatment. And again, this is either for yourself or for the patients that you work with and support. So what's the start? Jessica, you want to start?
That is loaded. Rare is hard. Rare is hard because when you are diagnosed, it takes forever to get diagnosed. I was having pain and issues with the peritoneal mesothelioma before I was diagnosed for almost 1.5 years. It was pushed off as menstrual issues. It was pushed off. I ended up in the ER on a work trip once in extreme pain, and they told me I had a stomach bug and I had anxiety. And to go home, and they gave me anxiety pills and something for nausea. The issue there is insurance is very hard to get diagnostic testing. When you're looking at me and you see a young, semi-healthy female at that time, young, the odds are that that's not what I have. And so trying to get insurance to do those testing, it's hard. And, they go for the lowest common denominator. So they had an ultrasound first. Of course, the ultrasound didn't find anything, so you're fine. And then you have to push and push and push. So the diagnostic and getting that diagnosis, first of all, is hard. And then you move on to trying to find an expert in the field. With this disease especially, if you do not find an expert, you're dead within 18 months, and that's just part of it. I was very lucky. I live in Springfield. There is an expert, Dr. Kindler, at University of Chicago, so I did not have to go too far. But I had my surgery out of state. At that time, it was a very innovative surgery. It's the reason I'm still here. And it's called HIPIC chemotherapy and cytoreductive surgery. Getting there, going out of state, insurance issues is insane. It's extremely expensive. I believe I know my surgery and hospital stay afterwards were well over $250,000, and I know that because I ended up having to pay every penny out of pocket. And that is not something that should happen to people like us. I've worked with patients that have said, I would rather die than leave my family penniless, and they do, and that is horrific. So that, there's so many barriers beyond that, and then you have travel expenses because you have to get to those places. But centers of excellence and trying to find those doctors, those are all very hard things to do with a rare disease.
I don't know what is on. Okay. Thank you. And I echo, rare is hard. And maybe that's why I keep in it, because it definitely is rewarding when you can see things, see progress being made. I'll use the example that's similar to Jessica's in spinal muscular atrophy. If you're not familiar, the worst form, the kids are born and happy, healthy babies. Within the first few months, they start seeing symptoms, developmental delays, those types of things. And we learned from parents before newborn screening that they would go to physician to physician to physician, similar to what you see in many rare diseases, without a diagnosis. A pediatrician might say, well, your baby's lazy. We heard that a lot. Not trying to, there's wonderful pediatricians out there, but again, generally they're not looking for that zebra, right? That rare disease. So the diagnostic odyssey is incredibly difficult. And on top of that, often in rare, there isn't a lot of data to support bringing clinical trials, natural history studies, things that would support bringing therapies to the market. So, I think that's where advocacy, and always starting with usually patients and parents who then get together, understand what needs to happen, and perhaps working with academic centers come bring those things together. And it's those advocacy groups that help industry bring these therapies forward. And so I think that it's incredibly valuable to have genetic testing programs, newborn screening programs where appropriate. I could echo a similar story in Rhett. Again, these girls are happy, healthy 2-year-olds, and then they develop disease again, trying to find out. I think the genetics have gotten better, the testing has gotten better, but there's still a lot of work that can be done in rare to help patients get that diagnosis. That's the first step, right? Because often so much time goes by that the time they get a diagnosis, there's not a lot. Even if it's physical therapy, occupational therapy, that can't be done.
So Emily, don't let me forget to come back to the advocacy piece, and we'll talk about that a little more with John. And Jessica, if you don't mind, do you mind going a little deeper? You mentioned the challenge with diagnosis, misdiagnosis, lack of diagnosis, the challenge in finding the right provider, the right expert. What did you do? Where did you go?
So mine's a little unique. So I was under the care of a local oncologist anyway, because I had a melanoma the year and a half before I was diagnosed. So lucky me, that was a lucky thing for me, because I was able to push in that area to get more diagnostic testing. However, when I was first having those symptoms, it was always pushed off as women problems. You're having bad periods. You're, you probably have a cyst. It'll go away. Every single woman of my age of childbearing years that I've talked to with peritoneal mesothelioma, it's exactly the same. It's always misdiagnosed as having issues within that area. So starting from there, I really pushed my oncologist when I got to the point after that ER visit, after having so much pain, something is wrong. I know my body. This isn't just whatever everyone else says it is. It's not anxiety. I am not crazy. They want you to believe you're crazy before they will give you the tests to give you a diagnosis. So she really pushed for me to finally get that MRI, and the MRI showed a small something. Within that small something, she said, okay, we can wait and watch it, or we can go in and I could possibly get a biopsy approved. And I said, no, I'm done. Get a biopsy approved. So we went in and I saw a oncologist, because of course they thought that's what it was. They went in, and I remember waking up from surgery, and she came in and she's like, I don't know what it is, but it's everywhere. There's thousands of tumors. It's not gynecological related. We're gonna have to send samples off to Cleveland Clinic to figure out what it was. It was another month before I was diagnosed with mesothelioma. If I was taken seriously a year and a half before that, those thousands of tumors would have been a few. I would not have gone through the intense surgery that I have, and you continue to have problems after surgeries like that. They call it the godfather or the daddy of surgeries, the father of surgeries, because it's the most intense surgery you can have. Because I did not know that a human could live without so many organs because they take so much from you. So from that period on, it's so important with a rare disease to get that diagnosis early, because that means life or death. If you get to that point where it's too far along, that's it. That's my main issue with rare disease and diagnostics.
You were a significant advocate for yourself.
I had to be.
Yeah.
I had to be because no one else was. And even beyond that, trying to figure out where to go. I had an option to go to St. Louis, somebody who was just started doing this HIPIC surgery that was very innovative at the time, but they had no experience with mesothelioma. There was one doctor in Wisconsin that had seen mesothelioma patients and done HIPIC a few times, so that's where I was able to go. There was another one out in Wyoming, and that was more travel for me, so I was able to go up to and just drive and not have to fly to Wisconsin to get that done.
Thank you for sharing that.
Of course.
So then, Emily, from your organization, where do you all step in from an advocacy standpoint? Where do you find yourselves having to provide any support?
It depends. Typically, in the case of Rett syndrome today, and even spinal muscular atrophy, the beautiful thing is there were, there are organizations now that started with parents that have built up the infrastructure to a certain extent, right? And so what we try to do is, when working with our advocacy partners, is understand, what are they working on, what are their needs, and then help to educate them on what it takes to bring, in our case, a gene therapy from the initial science, which a lot of these groups fund, whether it's through an academic institution. Actually, our gene therapy program started by funding with a small organization, and then came through UT Southwestern when we came in to bring it into clinical trials into the IND stage. But it's kind of this intersection between where their goals are, of course, and what we need to bring something to market. So in the case of spinal muscular atrophy, it was very clear that early diagnosis was incredibly important. In order for a gene therapy to be effective, or any therapy to be effective, you had to treat as early as possible, and ideally before symptoms came. So we partnered with Cure SMA, which is actually another Illinois-based institution, advocacy group, Cure SMA, on, and as did many other companies that were working in the spinal muscular atrophy. So talk about companies coming together for one cause with the advocacy group to help bring newborn screening forward so that kids could get tested, and then whatever therapy they went on, they could see the benefits. And I'll give an example of someone who was treated at birth with newborn screening that now is 6 years old. It's still friends with his family on Facebook, and you see, going to school, walking, where these kids would normally either be on a permanent ventilator at the age of 2 or no longer be here. They're in it, that's just the importance of, again, and there's now multiple therapies in that space. Other ways to partner with them include education, even educating broader stakeholders, because who in this room knows what Rett syndrome is? It's good, yeah. Okay. So it's a rare disease, so just broader awareness that we can help, and again, partnering with our advocacy groups to bring greater awareness to Rett syndrome. I won't go down the path of Rett syndrome for the group, but it's certainly, again, it's ways to broadly educate and partner with our advocacy groups. And yeah.
Thanks, Emily. I'm going to look at you, maybe Olivia. I didn't bring my phone up, so I don't know what time it is, so let me know how much more time we have, so I don't go too far. I think you still have, you're great. 20, 30 minutes? Okay, because we want to leave time for questions. And diagnostic odyssey, you use that term, Emily, I don't know how timely we are to the big movie itself, right? But diagnostic odyssey is such a great term to talk about the challenge, right? Because it is significant to navigate. I've been in the industry for a long time, and we know it takes years of trials and failures before a treatment can ever get to the market. And a lot of people believe that once a treatment exists, it's accessible to patients, and that they'll be able to receive it. So we know that that's not always the case. So can you speak to some of the barriers that patients encounter after our therapy is available? So you've gotten through the diagnostic piece, right? Now we know what it is. A treatment is available, but now you have to try to get it. Can you speak to some of that?
It's challenging, right? And you spoke to it, Jessica, even with surgical options, finding the right centers, and it's the same in rare. So obviously the diagnosis is the most important piece. Without a diagnosis, you can't get treatment. Then once treatments become available, certainly there's hurdles with the payer level, and that's where education comes in partnership with advocacy, again, comes in, because our advocacy partners can educate the appropriate folks. But yeah, the time it takes perhaps to get on a payer plan, the time it takes to get on a Medicaid plan, and it's the patients and families and advocacy groups that are often writing the letters, going to Medicaid meetings, standing up. But yes, it can be it is a challenge, especially early on once a therapy is approved. And in the case often with, I'll say, gene therapies that are one-time administered, in the spine, it's making sure you have those centers of excellence that can dose the family, follow the patient after they're dosed as well. So it's the access to the actual therapy, and then the access to the treatment center once it's approved as well. And this is where collaboration is so important.
Jessica, you want to speak to that as well?
A big thing with my disease and my cancer, but also within my bleeding disorder rare space, are clinical trials. And so I'm kind of on both sides of it. I see the clinical trial space. I've been under many studies and clinical trials because of my gene mutation and because of my cancer. My blood is everywhere. My biopsies are everywhere. I will freely give it out to study. But trying to get into a clinical trial is very hard, depending on which doctors have it and which centers have it and where you have to go, and even qualifying for those trials. Some of them you have to never had any surgeries or any chemotherapies or any treatments before. Some of them you've had to run the gamut, and then they want you, if you are stage 4 or very close to passing away, that's where you are qualified. So it's very hard to get into those. And once they're approved and they get to that stage, getting to those places, and then payment and insurance and how you have to figure that out, because you're not only battling your disease, you're battling trying to get to that source that's going to save your life, but you're also on the phone with insurance constantly. I think the fact that insurance companies can override doctors is criminal. And I will say that until the day I die. I don't think that should happen. And the mental hurdles that you have to go through being diagnosed and then having to go through battling that is quite a lot.
So the title of this session this morning is the intersection between innovation and the patient journey. And John's not just here because he's great. John, if you could maybe speak to that innovation challenge when you think about the industry, you represent the breadth of the industry and the ecosystem. Can you speak to some of those challenges as we look to innovate and bring things to market so that patients can have access?
Yeah, I mean, I think a lot of what we do is listen, right? And that's what I've been doing this morning, listening to patients, listening to their challenges, listening to our company's challenges, and then we try to connect and educate and provide those kind of forums to educate. So we do have that kind of interesting intersection of working with patients, working with policy, and then also working with our community. And one piece of education that we always try to bring up is this industry is not a one-size-fit-all industry, right? So if you're coming in and when we look at these kind of policies that you have coming through, what you're doing for a drug that is a mass market drug that millions and millions and millions of people are taking, and you're trying to do a policy focused on that drug and that specific issue, it has an impact across the board for all of these other companies that don't fit that same kind of model. And that's where we're trying to do a lot of kind of education of like, look, yeah, you have a drug that is going to be mass marketed across the country and everybody's going to be taking it basically at some point. But then you have drugs where just a couple people are taking it. And how do we build in this ecosystem a way to make sure that funding exists to support innovation in that area? And that's where, we have to look at all of these programs that exist now with the FDA that allow for, priority review is operating. I think that break in the priority review vouchers was huge. A lot of our companies were reaching out. A lot of our smaller innovation companies were relying on those vouchers. And without getting that kind of renewed, it would have really created a huge problem for our industry. And that's where, once again, on that innovation side, that patient voice is what's most critical, right? Because we can go in and we can talk about the business aspect of it. But the first thing that was said here, I think today, was it's all about the patient, right? And so the business only supports the ability to bring that drug to the patient. And so making sure that patient's voice and policymakers know that, yeah, we're pushing hard on these vouchers, we're pushing hard on these things, it's because this part of the industry needs help, and you need to have that patient voice to kind of say, like, yes, like, we need hope, and these programs provide hope for us that there's going to be an innovation that's going to help us, or there's going to be continued investment into this area. I mean, I think we talk about SMA. I mean, SMA is a great example of a drug that came out, and the continued innovation in that space on it has been amazing. And that's what we need across the board with all of these other kind of diseases, and it's that education piece, I think, that is most important. So.
Thank you, Jen. That's great. So we're here at MDSL. Don't know if there are any policymakers in the room. We hope so. And such significant partners for this work, right? So critical. And policymakers play a really important role in shaping the healthcare environment. Are there examples of policies, and any one of you can answer this, that you've seen that have been positive and beneficial, that are supporting innovative treatments and access to innovative treatments? We'd like to get to a point of solutions. I know we have some things that are challenges, we can speak to those too. But maybe we'll go there first. Maybe we'll start with some of the challenges with innovation. And maybe I'll put an example out that we've seen in Illinois. And others in the room can speak up that were involved in this too, but we have an example of well-intended policy that causes unintended consequences, right? That directly impact patients. So can you speak to maybe a prescription drug affordability board, for example, or other examples, what those are for those that may not know, and why that may be challenging?
Yeah, I think I'll kick it off. And I think there are a lot of us in the room who are still reliving this past spring in Springfield on this, and really all across the country. And once again, I think the well-intended piece is what's important, right? And so I don't think anybody that's bringing nobody has ill intent when it comes to trying to make sure that patients are paying less at the pharmacy counter. I think it gets back to what I said just a minute ago of, you have this policy idea and you think, it's this broad base, but you don't understand how it impacts kind of everything. So prescription drug affordability, does everybody know what a prescription drug affordability board is? All right. There's not a whole lot of shaking of heads, so yeah.
Well, maybe that's a good thing.
So essentially what it is it's at least in Illinois, the way that they want to do is they want to create an independent unit of government that's going to have a board that's going to review the drugs and then set a reimbursement limit on that drug with the intent of reducing the costs to the patient. I think you hear that and it sounds, not to me because we've been living in it, but I think for a general person, like, okay, it's going to reduce the price of drugs. But you have to understand how the system works. And we're wrapped up in this time now where affordability is a very key word. We're hearing affordability a lot, but you can't take affordability in the grocery store and affordability in gas prices and affordability in all these other industries and apply it to the medical industry because it is so complex. I've been doing this now for 22 years and I still don't completely understand it, right? But we have this crazy system that exists in the United States, and this is where that unintended consequences comes up because if you don't understand how it all works, there's something bad's going to happen. And so that's why when we phrase it and we look at these kind of issues, we say, well, it's an access issue for our industry, right? We want to make sure that patients are getting the drugs that they need to get as soon as possible and they have access to it. So what the concern with the Prescription Drug Affordability Board is that it creates that access problem. If you're setting a limit on what a pharmacy can get reimbursed for a drug, that pharmacy may not be able to carry that drug. And that is what the big concern in the rare disease community is. And it's also, if you're looking at, once again, the whole ecosystem, are you de-incentivizing investment and research into specific areas if you are trying to de-incentivize the reimbursement for that area as well? And so I think when you take a look at it, it's just a very complex issue, and I'm having a little bit of PTSD from it from this past year, but it's a lot of education. I think that's where the patient voice, once again, was the kind of most critical piece of it, is understanding, like, how does this impact a patient actually receiving a medication, and bringing the right voices to the table to talk about it.
Jessica, do you want to speak to that?
I can kind of speak to it just on the patient side that deductibles and copays are a killer, and trying to get access to medications can sometimes be extremely hard. My focus in the last couple years has been very federally driven because of the CDMRP cuts, and I'm not sure if you're aware of the new OMB. They're trying to get where I actually have it written down, to CFR Part 200, They're trying to get rid of peer review and put in a political appointee to say whether research can go forward or not, and that needs to die a horrible death. And so that's where my focus has been, but I can tell you on a very rudimental area or a way that we need options as far as having those medications to us, but also affordability. When, as a patient, we constantly, or at least I am constantly looking at which pharmacy is cheaper for my medications. And then beyond, if my insurance is gonna be a better option, or is, can I find a coupon online that's gonna be better, that takes so much work and so much stress, and that's something that, you know, as far as the patient is concerned, that we should not have to do.
So I think we're gonna go to questions, but maybe I'll give each of you, maybe if you just wanna jump in really quickly with a very high level, what can we do together, right? Where have you seen the positive example of how we've seen all of us work together? Any suggestions, or the thing we need to be focused on, like what you're focusing on at the federal level? Okay. Whoever wants to jump in.
Do you wanna go first? Unless you can.
I think John said very well when he talked about hope. Hope is a huge thing for us, and I remember when I was first diagnosed, you know, thinking I wouldn't be around another year, that, you know, if I could make it one more year, something new might be on the market. If I can make it just one more year, and you know, if my disease specifically with the mesothelioma is not a one and done thing. It's always around. It's always there. And I'm going to continue to have treatment throughout my life, and I have been, if I continue to live with this disease. I had a friend that just passed away, unfortunately. He lived 25 years, which was amazing, because she had HIPIC and other things. I would love to get to that 25-year mark. That would be amazing. But every single year I make it, something else might be out there, and that is the hope I have, and that is the hope every other patient has. So what you are doing is amazing, but bring us in. We know what we are experiencing. We have a heart for what we're doing. We are out there and we are pushing and we are fighting. And I hope that I will give every one of you my personal number. You can call me and talk to me and say, hey, this is what we have, what can we do? And I will do my best for you. But I would say just, you know, always remember that we are there and we are the end user. And everything that you can do to make what you are developing accessible will help us get to that next year. So that would be my final thing, is just, you know, we're here and bring us in.
And I think that's a great final thing. Let's open it up. We have a few minutes for questions. Let's open it up for questions. Anyone have a question? So good. Yes.
So can I just make the comment, John, you're very kind, to say that there is no one that's really out in the PDAB space with any malintent. I think there is. And the reason I say that is that the premise of it is that innovators in this country are somehow bad actors, and that the innovators have a requirement and a duty to be on the market without any intent to profit from the risk-based capital they invest in therapies. And the people that are pushing PDABs, and I think it's true with copay accumulators, make innovators the bad guy. And without those innovators, we're left defenseless. We're then go to a socialized medicine system that delivers no innovation. It delivers no great leaps and bounds, and the most vulnerable of all of that space for capital are rare disease therapies. Because risk capital in rare disease is extremely high, little return, and without incentives built in, instead of the disincentives with PDABs and the disincentives with copays, restrictions, that kind of thing. I just think we need to sharpen our approach to this to call out those people that make the innovators the bad guys in this system, my opinion.
I don't necessarily disagree with you. I think my comment was political, right? Because I don't know who's in the room. And if we were in a private conversation, I would have echoed the same. But I mean, it's either a lack of wanting, or it's either a lack of understanding or a lack of wanting to understand because it supports a policy position or a political position, right? And so I think you get into this political versus policy, and this is where PDAB lives right now. Is politically, it's a great talking point. We're going to reduce drug prices. We don't care how, but the reality of that is they don't really care how they do it, as long as they can check that box saying that they did it. And we've had too many conversations with policymakers saying, and I'll be a little bit more blunt now, I don't care if there are wrinkles, we can try to figure that out. And our response is, those wrinkles are patients not getting drugs. And that's putting lives at risk. So that's not a wrinkle. That is a huge issue that you're trying to create. So yeah, I do agree with you. Politically, how to call them out specifically, I think that is a challenge that we will work on. But there needs to be more education about this, and there is a mind wall that exists on this issue that we have to try to break through. And I talked with even a couple people today about how do we start to bring that forward next year as well. So.
Excellent. Thank you.
I can take us to a more positive note. On newborn screening, it was mentioned briefly, and in lieu of Erin being here, I'll be the newborn screening advocate. There was a great bill that passed this year. I think it's awaiting governor's signature as we speak, SB 3049. And that basically the committee at the federal level, if people are familiar, got disbanded last year, the added conditions to the newborn screening panel. And Illinois is leading, one of two states that passed kind of a solution that we hope to have the state lead in terms of adding new conditions. So, and it sounds like there was more leading on SMA and other conditions before that. So maybe if you could speak more to how Illinois is leading and how other states could kind of look towards that process, as I hope they do. And that's been my main topic of conversation at NCSL.
And I think that was a great example of the system coming together to work on an issue, right? And it was industry bringing it forward. It was patients, highlighting an issue. It was industry bringing a solution forward. It was policymakers at the federal level or at the state level that heard that and understood it and wanted to make a change. And it was also the state. I mean, fortunately, in a year where Illinois has zero budget, they actually had excess budget for newborn screening. And so that made our issue a lot easier at the state because they had access to funds to help expand it. But that is one of those issues where it was a very positive kind of step forward. So yeah.
I have a quick question. And this is something that Jessica mentioned that really struck home with me. I have a mother with an autoimmune rare, and it took her so long to get diagnosed to the point where she almost died a couple times. And it was that, well, you're a woman, so how do we educate physicians and those people on that diagnostic journey that being a woman isn't a disease, and it's not the cause of every issue, and how do we get those diagnoses faster without having to hit all those roadblocks continually? Because every time her insurance changed, there's a new doctor, start from zero, that step therapy, let's try this. How do we really increase that education so we get those diagnoses faster?
It's a hurdle, and it is widespread. I think, again, it's the lesser of all evils. Of course, it's got to be this first. And it's also about advocating. I think the patients need to be better advocates for themselves, but they also need to be heard. And we aren't being heard a lot of times. Another thing that on my journey specifically is when I was diagnosed, I did not have children and I wanted to preserve fertility. I luckily had good enough insurance that I was able to access that, but there was only one fertility doctor in there, and I had to delay surgery 5 months so I could see him to see if I could do that. I was too far advanced to be able to save any eggs. I was very lucky that I talked to my surgeon who wanted to take everything. I'm like, leave my uterus and at least one ovary if you can. He was able to. I was able to have 2 children via IVF afterwards, and fertility help. And that was a very hard decision and a whole thing in and of itself. But having access to those options, but also that's such a multifaceted thing. I mean, doctors really need to understand that we know our bodies better than maybe what they were taught in school. They need to listen to us. And if we're saying, no, it's not this, please push and get us the testing that we need to do that. And we aren't crazy. And I think a lot of that is like, it's in your head. Maybe you think it's worse than it is. That's so multifaceted. I could speak on that for a very long time, but it is a problem in this country, and we need to be heard. And I think that really starts at the lowest level for the patient pushing, but also the doctors need to say, we're going to go kind of back against those insurance companies too and say, there is something wrong, we need to push for more testing.
If anyone ever said there are not biases and health equity issues in this country, they are not telling the truth.
Absolutely.
It's significant. It's women, and it goes beyond. And rare disease falls into that category.
And I will say, in Illinois, at least this year, we did have a bill pass and the governor, I think, has already signed it, or he's about to sign it. That's to require more education of general practitioners on women's health to start to push that forward. So I think that's another good area where Illinois is starting to lead and lean forward on that a little bit. But I think there's a lot more that can be done. So speaking as a man who has a wife, and, I don't understand and I need to learn more. So.
And last I heard, we all came from a woman.
Yeah.
Let's do one more question. One more. Yes.
This is more of a comment, and I'm sorry, I know this is a question part, but you mentioned legislators saying we'll work out the wrinkles, and in my professional capacity, I'm a lobbyist, so I hear this all the time. We'll fix it next session, et cetera. But in my real world, that really matters to me. I'm a rare disease dad, and when I hear people say things like, we'll fix it next session, we'll fix it, we'll iron out the wrinkles, it's so callous, because those wrinkles are human lives, and we, Jessica, you certainly know this, I think we all know this, but we don't have time. Time is the thing we don't have. We don't have till next session. We don't have till next anything. We need innovation now. We need therapies now. And putting in roadblocks like, oh, we'll fix it down the road, especially when we know that there are problems. You mentioned the PDAPs, when we know there are problems at the front end and we still go forward with this policy, it's just not acceptable. We don't have that. And you mentioned the PRV. Yes, it was reauthorized, but that took over a year. And that's a year of lost innovation, lost investment, let's be real, lost people. Yeah. That's what this policy translates to in the real world. And so when I hear those kind of words from folks, from policymakers, it just reminds me of why all of you, why it's so vital to have Jessica in the room with you when you're doing this advocacy, to have, my child in the room with you, so that we can translate to these policymakers who have the vote what they're actually working on. It's not letters, it's not PDABs, it's not PRVs, it's human lives. And if they don't hear what those costs are and what those benefits can be, then you're not doing your job and they're not doing their jobs, and that's just not acceptable for me. So please keep, everybody says patient forward, patient focused, live it that way, and that's what I think that means, is have us in the room with you.
I think that's a great point, and I think that this isn't policy, this isn't political, this is human, and we are all human, I think, in this room. And when you get down to the point of it, it's about lives. It's about lives, and we have to keep that at the front of every story we tell and everything that we do.
Well said. We have to be louder, and we have to be louder together. Please join me in thanking our
I just want to thank the panel and Jessica. Your story is just like my dad's story. And he was diagnosed after he had symptoms. And then, of course, they found the tumors through his abdomen. And at the time, they didn't have therapies. And just the joy of you seeing it tomorrow tells you something about the distance between the time my dad was diagnosed with a terminal rare disease and today. The innovation, the bridging for future for patients. And that's what it's all about. So thank you. Very powerful panel. Thank you to each of you for being here with us this morning. Thank you to all of you for being here with RAAP. This is, as you've heard from some of our staff, this is a very personal mission for us here at RAAP. Most of our staff is rare impacted. We're aunts, we're uncles. I'm a son of rare patients. And so this is a very personal mission for us to ensure that patients have access to the innovations that are just out of their reach often because of some of these wrinkles. And so I want to thank you for that. For all of you, I just want to remind you, also today we have a Learning Hub panel at 1:30, and we are going to be unveiling some very important studies regarding some of these access issues. So our panel for this afternoon will be not only talking about access issues, but also some of the solutions and some of the patient-oriented solutions that we can push forward that will help bridge that gap between a medicine, a therapy, and the patient. And so that's in Learning Hall 2, and that's at 1:30. And we look forward to seeing all of you there. So again, thank you for joining us this morning, and we look forward to seeing you throughout this week.
I wish I